Hi, everyone. This is Barb Cochran. You can't see me, but you're hearing me via the magic of my computer. I'm the Associate Director for the Northwest Geriatrics Workforce Enhancement Center, and this is our ninth in a series of 10 lectures for the Geriatric Healthcare Series for spring term. And just want to remind you, since there's only one more lecture left, if you are wanting to get continuing education credits, you should contact your site coordinators, and they have the information for making that happen. And just a reminder to please complete your evaluation forms for this lecture and the one next week. And today I'm very happy to introduce to you Peggy Odegard. Dr. Odegard earned her Doctor of Pharmacy degree from the University of Washington in 1990 and her BS in Pharmacy from UW back in 1985. She's currently Professor and Associate Dean in the School of Pharmacy at UW, where her teaching and research emphases are on diabetes prevention and care with a focus on the needs of older adults. She's been a wonderful colleague to those of us in gerontology for quite some time. She practices pharmacy in an interdisciplinary care setting, provides community-based education on aging to older adults, and she's a certified diabetes educator, so you may see some of her archived lectures on diabetes as well. Prior to her position with the University of Washington, she worked in a community-based health system with responsibility for clinical pharmacy services, and we're pleased to have her today talk with us about medication use in older adults, keeping it real, safe, and effective. Welcome, Dr. Odegard.
Thank you, Barb. Hudson, is the mic on? Okay, everything's okay? All righty. Well, I'm looking forward to having the chance to chat with you today about medication use in older adults. There are a number of things to consider, and I think we'll hopefully, through a theme of thinking about some of the key principles about how aging affects medications, but how medications can affect aging. We will pull through to the other side at the end of the session with hopefully some key ways that you can better support older adults with medications that they're taking. My objectives are that I'm hoping we can think about the key challenges associated with medicine use in older adults. Think about some of the physiologic changes that happen with aging that may impact medication use. Think about symptoms that sometimes can signal a medication-related problem. And then we'll take a look throughout this presentation at some cases and thinking about how to apply the principles that we're learning. So I wanted to start us out with a little bit of a self-test. So take a couple of minutes to look through these questions and just briefly think through how you would answer them, and then I'll go through them here in about a minute. Alrighty, so if you felt like you could answer all of them, that's wonderful. If you felt like you could answer none of them, that's wonderful, because that's what we're going to be talking about in this session. So the first question, the main reason that older adults require lower doses of medicines is an age-related decline in kidney function. The answer to that is true, and we'll look at that a bit more deeply, but that is really the most critical change in what we call pharmacokinetics of aging that affects medications. And many medications are cleared by your body through the kidneys, so that decline in kidney function over the years as we age can become a critical factor in medication safety. Question 2, older adults are more sensitive to most medicines than when they were younger. The answer to that is true. As we age, we have just an accentuated response to many medications. There are a few medications we might have a lesser response to because our receptors are just kind of not as sensitive anymore, but for the most part, older adults tend to be much more sensitive to medicines as they age, and we'll talk about that when we talk about some of the age-related changes. With increasing number of medicines, question 3, the risk also increases for what? Does it increase for drug interactions, adverse drug events or drug reactions, adherence challenges, or all of the above? And the answer is all of the above. The more medicines you're on, the more your chance of drug interactions, adverse drug reactions, and adherence challenges. Number 4, the prescribing cascade occurs when a medicine is added to a regimen to treat the side effects of another. That's true, and the prescribing cascade is something we can see in any of the age spectrum of life, but in particular we see it in aging. As people are on more medicines, they might have a side effect of the medicine that either they or their healthcare professional perceives as sometimes even a new condition. And so a medicine is added to treat that condition. So it might be, for example, if you're taking something for pain and it's upsetting your stomach, you might have something added on to treat the stomach, and that might cause headaches, and then you have something added on to treat a headache. And so you end up with this prescribing cascade where the appropriate approach would really be to consider the presentation of any new symptom or condition in an older adult as a potential for a drug-induced problem that is included in the differential diagnosis. And then number 5, older adults are at greater risk of falling due to their blood pressure medicine if they are dehydrated, they stand up too quickly, their dose is too high, or all of the above. And the answer is all of the above. Older adults are especially at risk for falling due to medications versus when they were young. And their blood pressure medicines are especially more effective. So in other words, could cause more of a risk of side effects like falling when someone's dehydrated. If you stand up too quickly because they have an altered baroreceptor response with aging, so their blood pressure doesn't correct itself as they stand up, or certainly if their dose is too high. So what I'd like to do now is we're going to kind of cruise through some principles about aging and mix in some cases and really think about how we can really hone in our attention to be at best support to the patients or clients that we work with. So the first principle is to think about that in general, we're more likely to take medications as we get older than when we were younger. It may not be a reality that people like, but it happens to be true, and the data supports that. Older adults are the highest consumers of medication in the United States. A more recent study, there's been studies done for many years, but a more recent study done in 2015 actually showed that 90% of people 65 and older report using one or more prescription drugs in the past 30 days. 40% took greater than or equal to 5 medications, and 20% were taking 10 or more medications. Of that sample, 42% were taking at least one over-the-counter medication, so it didn't loop into that prescription drug data. And then 49% were taking at least one supplement. So when you add together over-the-counter medications, supplements, and prescription medications, people can end up on quite a few medications. And as you can see, with 40% taking 5 or more medications, there's a lot of potential things for someone to balance, and a lot of potential effects, good effects and bad effects of those medications that we have to be watchful for. I'd also like to point out that so many over-the-counter medications and supplements are available outside of pharmacies now, or available online. So a lot of times patients are informing themselves or gaining advice from someone who may or may not be medically trained on what they should be taking. And so really helping, I think, for all of us who interact with our older adult clients to really help understand everything they're taking and update that med list so that their health professionals have an updated copy of prescription meds, non-prescription treatments, remedies, supplements, everything that they're taking is really helpful. So the most common medications that older adults were taking, you can see listed here. And they're the very common drugs: aspirin, so low-dose aspirin, which you can get over the counter, simvastatin, lisinopril, hydrochlorothiazide, so medications for blood pressure or heart failure in the lisinopril case, levothyroxine, and you can see on down the list, primarily blood pressure, cholesterol, or heart failure or diabetes drugs, or some of the stomach drugs also. So what's the concern with this? Well, The problem is that taking multiple medicines, it does increase our risk for side effects. It increases the risk of drugs interacting with each other. And I haven't listed here, but it also increases the risk of a drug interacting with a disease state. So drugs can make a disease state worse, and that's concerning because you don't want a drug to interact with a disease state that you're trying to treat and monitor and gain improvement with. And then multiple medicines can also challenge self-management, or what is otherwise known as adherence. And I think that's important to note that the studies show with adherence that once someone is taking more than 2 doses a day, so taking a medication more than twice a day, so that could be 1 medication taking twice a day, or 2 medications taking once a day at different times. But once they go above that level, adherence really starts to be affected. And people, as we all who work with older adults or anyone on medications know, including possibly yourself, medication adherence is not predictive across all their medications. Sometimes it's selective. So if they have a medication that doesn't make them feel good, they might be less adherent to that. If they have a medication that they're very clear on why they need to take it and they're motivated to take that because of the goal they want to achieve, they might be more adherent to that one. So really helping assess how someone's doing taking their medications is an important intervention. Ideally, we want people to be on the fewest medicines possible and optimizing non-drug therapies. Yes, I'm the pharmacist, and that is what I say all the time working in geriatrics. I have friends who call me and say, Peggy, I've got this, what should I take? And I'm like, well, first of all, what you should do is this. And examples are insomnia. You know, any sleep agent increases your risk for falls, especially if you're older. And so if your insomnia is being caused by stress, then manage your stress or do something to help manage your stress. If it's being caused by too much caffeine, change your caffeine intake. But if you need exercise, you know, whatever it is, try those non-drug treatments first before moving to a drug. And I think sometimes my friends don't call me anymore because they don't get the answer they want because I'm encouraging them to adjust their lifestyle in some cases. So the second principle that this kind of leads us to, though, is older adults are a very heterogeneous group. Their healthcare needs are not the same, and so we need to individualize care, taking into account their preferences and goals. So there might be someone who wants no medications if they can avoid them, and so we have to really then work with them on, are there medication, non-medication related strategies to treat illness? And if a medication is truly the curative factor that they need to be on, we need to also think about how to coach them that that medication might be necessary. But I think the other thing is to think that care needs to be individualized, and as we age, our needs do change. So I have a little kind of depiction here of how it might change. So, and the importance of tailoring and individualizing therapy as someone gets older. So what worked at 65 might not work at 85. So here's a 65-year-old woman with high blood pressure, diagnosed at 65. She's independent in her functional status. She wants to prevent stroke or MI. There's a target goal you can see there of less than 130/90. And she's ultimately placed on 3 medications for that blood pressure management to achieve that goal. By 75, she now has another medical condition, osteoarthritis. She's having difficulty with a couple of ADLs. She still wants to prevent a stroke or a heart attack. Her goal needs to be individualized for the fact she's 10 years older and what the data predicts, and also any risks of that therapy. So in this case, the goal has been individualized up to about less than 140/90. And she's reduced to 2 medications. That same patient at 85 now has dementia, in addition to hypertension and osteoarthritis, is having difficulty with 6 activities of daily living. And her goals of care are palliative. I don't really want you to do anything heroic. You know, let me know if I really need to be taking these medications. So then it really begs to start thinking about, do you keep treating that blood pressure? And if her blood pressure is pretty stable and has been for years, how do you start withdrawing medications to keep her within a safe target so she doesn't have a stroke or a heart attack that you could prevent? But then how do you help her understand the adjustment of those goals? So Dr. Cochran mentioned, I work in diabetes. This happens in diabetes a lot because people with type 2 diabetes often have it for many years. They may be diagnosed in their 40s or 50s and have it through their, you know, the end of life. And I've been in healthcare long enough to have seen people through many years of diabetes. And I find it is challenging for a patient when a goal for diabetes, for example, an A1C of less than 7% was described to them 15 years ago. And now we're saying, you know, we're gonna lighten that up a bit and take it to less than 8% because we feel that's safer for you. I have patients look right at me and said, you did all this convincing of me to get my A1C less than 7, and now you're telling me that's wrong. And I'm like, it's not wrong. It's just time has gone on, and we need to keep you safe. And the risks of a low blood sugar by keeping that therapy really tight might outweigh, you know, the benefit of keeping you on it. So helping patients with a lot of counseling to understand things do change over time. And it's important to have someone, ideally your PCP or a regular healthcare provider, review your meds every year to really make sure you still need to be on them all and that the goals for what the treatment targets are the same. So for drug therapy in frail older adults, we do need to think about, you know, as that lifespan goes on, adjusting the goals of care and thinking about remaining life expectancy and how much time does someone need to be on a therapy till they get a potential benefit of the therapy. So some medications for secondary prevention require a couple of years before you really realize the benefit on reduction in mortality. Some preventative therapies require 8 to 10 years before you realize the real reduction in mortality with that benefit. And so if someone's predicted life expectancy is just a few years, you really have to think about, is it worth starting this new drug to try and achieve a goal that's 7 to 8 to 10 years out? So you have to, I think we have to constantly really be in communication with patients about the goals of therapy and what our goal of care is. Is it prevention? Is it a cure? Or is it palliation? Here's an example. So with lipid treatment, you gain a benefit in about 2 to 3 years of reducing lipids, in particular in lowering LDL or in increasing HDL. And so the benefit is big. It's a reduced risk of stroke and MI, and it has benefits on morbidity and mortality. So you need 2 to 3 years of treatment. And the studies with lipids go pretty far out into at least the 7th decade of life and a little bit into the 8th decade. Blood pressure, again, you need about 2 to 3 years of treatment at that target before you really start seeing that benefit of therapy. It's not to say that someone doesn't have the benefit once they start taking it, but in order to really start seeing the long-term change in their mortality because of reduction of blood pressure, it would take a couple of years. Blood glucose needs about 8 years of treatment in the more normalized zones before you start seeing real changes in cardiovascular mortality and the macro and microvascular disease. So cardiovascular would be macrovascular disease, and microvascular disease would be more like reduction in kidney function due to hyperglycemia or neuropathies. So you can see, you have to really step back when someone has a new condition and think about, are we trying to prevent the condition or cure it? If we're trying, or are we palliating it or just controlling it? If we're trying to prevent it, how long do we need to treat them before we see that prevention benefit? If we're trying to treat it, ideally to a cure, will they make it in time to that cure? And I think those are all important considerations. And as we all know, it's very difficult to predict life expectancy. But I think having some awareness about the data for some of these drugs that really drive some important outcomes in reducing stroke and heart attack, and in some cases lack of data when you get into the later 8th and 9th decades, and certainly into the 10th decade of life. And working in geriatrics, probably all of us see people now who are over 100. So we have to think about the data that really drives the use of the drugs in that age group. So the third kind of brings us to the third principle, and that is that we've talked about here, adverse drug reaction risks increase with aging. And they increase for a few reasons, but they also can result in healthcare utilization, sometimes a lot of healthcare utilization because they won't be recognized as an adverse drug reaction. And the health consequences can be significant and potentially lead to functional decline. So with regard to healthcare utilization, I think it's important to think about that because, again, including drugs in the differential diagnosis of new onset symptoms or the workup for a condition is really important in aging, because if it's as simple as an adverse drug reaction that you can resolve by removing the drug, that's a huge factor. I think about a case I worked with when I worked in a geriatric clinic of a gentleman who had first headaches and then started having some confusion, and was sent to the ED for a full workup to make sure he wasn't having a stroke. But then he also was worked up with chest x-ray, urinary tract workup for UTI, pneumonia, got a CT for potential, mental status changes. And the bottom line was, as I'm back in the clinic and I'm working with his family on clarifying his med history, he was taking, I'm trying to think what it was 300, 600, it's taking about 750 milligrams of ranitidine, which is Zantac, a day, because he had been prescribed some. He had had some given to him by a friend to take for his stomach, and then someone in his family had picked up OTC Zantac for him to take. And the side effect of Zantac at really high doses is headaches, really strong headaches, but also you can start having confusion. And so that workup could have been as simple as recognizing right up front that really high dose, and then trying to just stop the drug and see if you had resolution of symptoms. So that's an example of high use of healthcare and high expense healthcare visit for something that was as simple as trying to identify really an overdose of a medication. So adverse drug reactions and that effect on functional decline is a really serious consideration for us to keep in mind. Here's a case of a 75-year-old active female. She visits her primary care provider with a 1-month history of sleep complaints. She says, I just can't fall asleep at night. I'd like something to help. So she's prescribed Zolpidem, 10 milligrams, that goes by the brand name of Ambien, at bedtime as needed. So a week later, she's rushed to the emergency department after suffering a fall. X-ray reveals a right femur fracture. She has surgery, but she has really poor endurance with the exercises and the PT, and is sent to a skilled nursing facility for further rehab. A year later, she still requires the use of a walker. So there's a couple things that stand out with this case. One is, as I alluded to at the beginning, she had a condition that probably should have first been really worked up for what are any non-drug related treatments or lifestyle changes that she could have done to help with her sleep. Or drug-related changes, caffeine or alcohol can be contributors to poor sleep. The other thing is her Zolpidem dose was probably twice what she needed, and it does increase risk for falls, even in an active older adult. So coaching her just up front on the fact, if she's going to use a sleep medication, letting her know this, first of all, using the right dose would have been a good idea. But then second of all, saying, this could potentially increase your risk of falls because you're going to be pretty foggy if you wake up at night. You might have a morning hangover on it. And so how are we going to prevent falls, and what strategies can we use to reduce that risk? So there's a couple things that could have been done up front. Remembering the other thing is any sleeper agent does increase the risk for falls. So a lot of questions that come in are, is there any list of agents we can just avoid? And one is to use a lot of caution with an older adult needing any medication to help with them with sleep. But there have been some studies done. So one of the studies that is often cited is a study that looked at emergency department visits in older adults. And what they found is that 4 medication or medication classes were implicated in 67% of those emergency room visits. They included warfarin, which goes by the brand name of Coumadin, so obviously bleeding-related incidences, insulin and various insulins causing hypoglycemia, oral antiplatelet agents, so that would be like Plavix or Xarelto, or to not use brand names would be clopidogrel for the Plavix, and then oral hypoglycemic agents. So that would be like glyburide or glipizide. And so those 4 classes have really surfaced over and over as high-risk drugs to use in older adults, but they may need to be used in older adults. So again, the counseling and coaching and safety education for patients is really important. And if the patient has cognitive decline, the counseling or coaching and safety education for their caregiver and family, whoever they're living with, is really important. So the 4th principle to pay attention to is some medicines cause effects that are perceived by older adults as just a normal part of aging. So I want you right now to just stop and think about, what's your paradigm of what's going to happen to your body as you age? What are the things, the creaks and the groans and the moans that you're just expecting to happen? Because sometimes medications can masquerade and create those symptoms, and an older adult will interpret, oh, it's just part of aging, and not go seek help, when it's actually could be a side effect that is preventable, resolvable due to a medication. So the most common ones we see are listed here: falls and fractures. Falls are often related to medications because they can impair your ability to walk as usual in many ways, and we'll talk about that. Memory problems and confusion is not unusual with medications that work through the central nervous system. A patient's family member one time came to me and I said, how's she doing? And she had had cancer and was receiving treatment for it. And he said, well, she's doing well, but we have a new problem we're dealing with now. She has dementia. She just can't remember anything. And I said, well, talk to me about her cancer treatment. Well, her cancer treatment included Ativan as one of the prep medications for the chemotherapy. Well, Ativan's side effect is amnesia. So she actually had drug-induced amnesia, not dementia. And he came back later and just actually gave me a huge hug. It was so excited that that was right, and that I can't remember her name, but he said she's back. She's actually back. And it was a medication-related thing. The family was actually going through a grieving process, and I'm sure she was, because they all believe she's really starting now to have dementia after we made it through this whole cancer situation. Urinary incontinence is another one that a lot of times people perceive, I'm old, doesn't this happen when you're old? And there's certainly a lot of advertisements on TVs for urinary incontinence products that reinforce that that's part of aging. It's not necessarily a normal part of aging. It is a geriatric syndrome, but it may be promoted by certain medications. And then constipation. A lot of times people think their bowel habits are going to change as they get older, so they don't pick up on the fact that their bowel habits are changing because of a new medication they started. Key culprits there, you're probably very aware of the opiates are key culprits in causing constipation. But one of the other classes of medications that people often don't pick up on is the calcium channel blockers. There's calcium channels in your gut, and they can be blocked by those calcium channel blockers, and yet people can have some constipation from the calcium channel blockers, especially that first 2 to 4 weeks after they start one. What's a calcium channel blocker? Would be like verapamil or diltiazem are examples of calcium channel blockers. So medications increase risk for falls in a pretty significant way for some meds. So there's very consistent evidence with the benzodiazepines, which are the Valium-like drugs. So those drugs tend to end in a PAM. So Valium is diazepam, there's lorazepam, there's tamazepam, oxazepam. Alprazolam is one that's in that family but doesn't end in that same word ending. And other sleep medications. So anything that impairs your central nervous system and makes you feel drowsy or dizzy is potentially going to increase your risk of falls. Antidepressants, especially the ones that are more sedating, antipsychotics, narcotics are sedating, and anticholinergics. And an anticholinergic that often people don't think about, and especially our patients because it's available over the counter, but probably one of the most serious on the list is diphenhydramine, which is Benadryl. It's a not used drug in older adults because it, in addition to causing anticholinergic symptoms like dry mouth and dry eyes and urinary retention, which can lead to incontinence, it can impair the central nervous system, and people can have falls related to anticholinergics. So pretty important list to be aware of, and ideally minimizing the need for older adults to be on these medications is the safest way to go. If they need to be on it, just coaching that patient that, you know, they need to be careful to watch out for the risk of falls. How do you know, if you're not someone who's familiar with medications, how do you know if they're on one of these? I would ask the patient on their meds, do you ever feel any effects of any of these medicines? So patients will often know. They'll say, well, this one right here makes me really dizzy, or I get kind of drowsy on it. If they tell you that, then it's really important to coach them. Hey, if you're feeling dizzy or drowsy, I would first report it to, you know, the provider who prescribed that. because there might be another alternate, or there might be a dose issue that they could change the dose to reduce that effect. But then also, if you're feeling drowsy or dizzy, you need to be really careful because you could easily be impaired and trip and fall. They also shouldn't be driving a car if they're drowsy or dizzy from a medication. So some medications that don't have consistent data, but we should use caution with, are the cardiovascular agents. They are affecting the heart, they're affecting the blood pressure, and certainly the drugs that can cause orthostatic hypotension if their dose is too high, we need to be watchful with those. So how do medications increase risk for falls? Well, there's several ways, and we've talked about some of the meds, but there's sensory changes. So like I talked about, Benadryl can cause dry eyes and blurred vision. That's an example of one of the ways it can increase risk for falls. Cardiovascular effects of medications would be most likely the ones that cause orthostatic hypotension. So especially if someone's on diuretics or a strong vasodilator, ACE inhibitors, especially if they're balanced against a certain volume of blood and then you get dehydrated, they're going to have a lot more effect. And then there's the neurologic effect of medication. So medications that cause sedation or reduce your alertness or your ability to process information, including walking information, are very, very important effects that can increase risk for falls. And if you have effects from multiple categories, you're really kind of a high falls risk on a medication. So some drugs can also cause cognitive impairment, and I've talked about a few of them, and the list on the left is very similar to the last list. But on the right, we have to remember drugs that cause electrolyte imbalances. So there are drugs that help us in a lot of ways, like diuretics, but sometimes diuretics can work too greatly and cause some electrolyte imbalances. So that's important to think about. Some of the older cardiovascular agents, you don't see reserpine or clonidine used as much anymore. You might see them in the rare patient or in certain medical situations, but those are high risk for cognitive impairment. And the corticosteroids. So an example of a corticosteroid is like prednisone or dexamethasone. And especially when used chronically, corticosteroids can have a number of psychiatric effects, including psychoses, but also are associated with depression. So I think it's important that if someone's on a corticosteroid, they're monitored pretty carefully for mental status changes or psychiatric concerns, but also a number of other conditions, as you probably know, like diabetes and some of the other effects of long-term steroids. So the next principle to think about is the more conditions you have, the more medications you might get prescribed. And that's a really hard one for people because they feel sometimes like every time they go with a new condition, they just get more medications. And especially I know in type 2 diabetes, you can sometimes have your day of diagnosis and walk out with 3 to 5 prescriptions because you instantly go in the category of needing something for your blood glucose, possibly something for your blood pressure, something to like a statin to reduce your risk of a heart attack or stroke. So there's often multiple medications that are thrown at someone when they have diabetes, and it can be pretty overwhelming. So my advice is whenever, I think too often we don't check in with patients about how are you doing with the medication regimen. Whenever a patient is sensing this is too complicated, there's too many medications, listen up, because they're the one living it. They're living the movie. We just see the photo when they come into the clinic. And so if they're really overwhelmed or feeling like there's too many meds, and I will tell you, working in geriatrics, I hear this all the time where patients will say, I feel like I'm on a lot of medicines. Do I have to be on all of these? And so it's really important if patients say that. I sit down and I go through every single medication. Sometimes I need to talk to others and get back to them or look more into the history. But I think it's really important to have a heads up around that. And if you work in a geri clinic, like in an ongoing ambulatory care situation, having patients no more than every 12 months, or no less than every 12 months, have their medication full regimen reviewed to make sure every medication is still needed. So how many is too many? Well, there's a couple things to pay attention to. We want to prevent that prescribing cascade I talked about, where one drug begets another, begets another, begets another, and all of a sudden the patient's on a number of drugs just merely treating side effects of the one prior to them. And so pretty important when a drug is needed to, again, make sure it's not a drug that's causing a problem, because the easiest treatment in that case is to remove the drug. And with most conditions, there's an alternate that you could put in its place if a drug is causing a problem. An example here that we might see in geriatrics provide some relevance for the prescribing cascade is thinking of it a little bit differently. Is, let's say donepezil, which is used in dementia, is the first drug. Well, donepezil can result in urinary incontinence. So somebody might then come in and be having problems with urinary incontinence, and the most likely thing is then to prescribe a drug for urinary incontinence. So in this example, it's toterodine, and toterodine works as an anticholinergic. So the reality is the donepezil is working on the cholinergic system, and then you introduce a drug to treat the side effect of the donepezil that actually potentially could reverse the effects of the donepezil. So it's a pretty serious drug disease interaction that you're creating, where the second drug added, yes, it's treating a side effect of the first drug, but you've got the double effect that it's also potentially countering the beneficial impact of the donepezil on the dementia progression. So that is an example of just stopping, looking at the big picture, and seeing, can we potentially change the donepezil to any other drug for the dementia that might not cause urinary incontinence. The other thing is that toterodine and a number of the urinary incontinence drugs in some studies have been shown not to be any more beneficial than Kegel exercises. And so depending on the extent of dementia, is a non-drug alternative possible, may or may not be possible in someone with advanced dementia, but something else to think about. So let's look at this case. So this is a 75-year-old female, and the question is, from her is, am I taking too many medications? So I took her med list here, and what I do as a pharmacist is I actually look at all the meds, and I think there's 11 on her list that she's taking routinely. Sounds like a lot of meds. I don't know that I would be able to really manage and would want to be taking 11 medications a day, but what I did is I put her meds on one side of the list, I put her medical conditions on the other side, and I try to at least match them up to see, does every drug have a home? And so I've matched them up by color on this slide, and hopefully you can see it on your handout, but the lisinopril, metoprolol, and furosemide are all connected to her heart failure, which started after her heart attack 7 years ago. The aspirin and the atorvastatin are connected to her coronary artery disease and prevention of a next heart attack. The calcium carbonate and vitamin D are connected to her osteoporosis, and the alendronate, sorry. The glipizide and the metformin are connected to her type 2 diabetes, and the glucosamine and chondroitin are connected to her pain in her back due to spinal compression fractures. So for me, this helps kind of organize it in my mind and gain some clarity around, okay, every drug has a home. Is every drug needed? There are some duplications, so not necessarily duplications of drugs, but we have in some cases double or triple drug therapy for conditions. So then my first step would be, I'd think about, is there any way to simplify this regimen? And there might be, for example, a way to have calcium, carbonate, and vitamin D in the same pill to simplify that. She might be able to switch to a monthly or yearly infusion of a bisphosphonate to avoid having to take a medication. The glipizide and metformin, you see, Barb mentioned I work in diabetes. For me, I just get all over stuff like that because that does come, you can get the metformin and the glipizide-like drugs in combos. So that might be another thing. So it may even be through some combo therapy pills that are all squashed into the same, multiple pills squashed into the same pill, that we could at least limit down the number of meds she's taking. But you know, the next step with this is to look at how well is her heart failure controlled, how well is her CAD controlled, and kind of take that next step in making decisions about, can we get rid of any of these, or do we need to just improve the treatment regimen so that it's not so onerous? It's a lot. And so the lisinopril, a lot of these are taken once a day, which is good. And the other thing I do as a pharmacist is I look very realistically, and you'll notice the title of the talk had real in it. I put that real in there because I think we need to be really real. What happens is there's the purist approach, with some drugs need to be taken on an empty stomach 30 minutes before, 2 hour, hour before, 2 hours after a meal. Some need to be taken 30 minutes before a meal. Some need to be taken with a meal. And the reality for the majority of drugs is the absorption effects by food are really quite minimal. And for the ones where it does have more of an impact, we're actually often measuring a level so we can titrate against that. So I try and go really simple with my older adult clients and say, when do you like to take your medications? And if they like to take them with breakfast and they have mostly once a day drugs, then I'm like, then go for it, because once a drug's at steady state, having something 30 minutes before a meal so you can have the peak effect before their meal is probably less of an issue. The drug that this patient wasn't on, but the one I'm talking about, thyroid, is often the one that will really trip people up because ideally it needs to be on an empty stomach. And if coordinating taking that on an empty stomach and then remembering to take other drugs is too challenging, they're not going to be taking some of their drugs if they have those challenges. So I guess I'm the realist. I try and come up with a more realistic plan. I have had other, usually pharmacists call me and say, why did you tell this person to take this for breakfast? And I'm like, here's the scoop. They weren't taking it before because having to coordinate it on an empty stomach, they just deprioritized it because they also think they need to take their meds with food. And so usually I try and be very realistic and make it as simple as possible to take all these medications. Ideally, we should be doing this for any age group that has to take a number of medications. So that's kind of how I approach looking at this. Is it too many medications? And I would sit down with Emma and kind of go over that and help her understand the groupings and then ask her what her goals are and say, in your ideal world, how many pills would be acceptable? Might not be that she wants to take. She probably doesn't want to take any of these, but how many would be acceptable? So the greater number or more often medications are taken each day, the greater the challenge to self-management. I mentioned that magic number of 2 or more times a day. So anytime medications can be taken once a day, and ideally if you're on multiple meds, if that once a day can be all at the same time, that's the ideal. Self-management, I think, is something that any of us, regardless of our professional background, if we're working in the care of older adults, can help inform and then triage and report if there's a challenge. So anytime we're working with our patients or clients, helping gain a sense of their understanding of their medications is important. Do they know the purpose for each medication? A lot of people don't know why they take different medications. Can you imagine if you had no idea why you were taking a medication, how unmotivating that would be to want to take it? So I've had a number of patients that just are joyful when they're like, thank you, no one ever told me this is for my blood pressure, and so helping them understand and writing it down, especially if you think that there's going to be a retention problem with the verbal education, how to take each medicine and any potential concerns. Any of us can ask the patient that, can you tell me how you take the medicine? And do you have any concerns about taking it? Depending on your professional background, you don't necessarily have to have the expertise to intervene, but if you can just help them identify they have concerns or they don't know how to take it, then you know where to triage to. Abilities. Are they able to read the prescription label and the instructions? Just as personal background, my research is in pharmacy practice interventions and in diabetes care. And in the diabetes care study we did about 10 years ago, we looked at adherence, and the most consistent factor for people that were challenged with adherence was they could not read the prescription label. So they either had problems knowing that was the drug they were supposed to take, or in many cases, they had never even really understood the directions. So an ability to read the prescription label is obviously a big factor with language, making sure it's language appropriate, but also font size appropriate. And as people age, if they have a more and more difficult time with the small font, they need to ask the pharmacy to have it in a larger font, or the pharmacy can actually sometimes just create a large font extra that comes with the prescription to help with clarifying that. Splitting, injecting, mixing, applying, all of the applying, an inch of something, and, all of the splitting pills, injecting things like insulin are all very challenging. They're challenging to people with dexterity in both hands and full cognition. So if you start affecting, and good vision. So if you start affecting any of the factors around how you might need to split a tablet, think about the split and all of that, you can really realize someone can't adhere to this regimen if they have to start doing a lot with it. And then can they swallow their pills? Really important consideration, especially post-stroke if there was concern about the airway. Because if you can't swallow the pills, they don't work. And so we need to make sure our patients can get them in. And there are alternates for people who have swallowing problems. There are some liquid formulations of many medications. There's also rapid dissolving strips that people can put on their tongue or tablets. And then what is their plan for adherence? Does the patient have a plan? That's a good question for any of us. But for example, does their dosing strategy match up with their ADLs? Think about yourself right now, or if you don't take any medications, think about someone you know who takes them. And if they've ever reported or you've ever experienced a challenge in taking a medication, think about, did you have that incorporated in with your ADL? So what do I mean by that? I've actually told patients to rubber band their prescription to their toothbrush so that if they have to take a bedtime dose, they remember to take it. And I've had patients tell me that's a very helpful strategy. I've had patients put their medications right with, like by their breakfast cereal, so that when they go to eat breakfast, they know they've got their medications there. So kind of matching it up with ADLs is important. And then again, making it as simple as possible for their routine. Pill organizers, blister packs, bingo cards, all of these are useful tools to support adherence that pharmacies can help with. So if you're aware of the patient's pharmacy and you know they're having a challenge, that's a great intervention, is just to contact them and see, are there some ways you can help this patient. Another thing pharmacies can do is they can synchronize refills so that they all happen at the same time. It means for a month or two they get off because they have to only give you like 27 of some pills and 83 of it, they have to kind of line them all up, but it can take a couple of months. But once they get synchronized, it's really nice because the patient, if you're on 11 medications, and you have 11 different pickup times for your refills, it can become a weekly or twice weekly job just picking up your prescriptions every month. And so synchronizing those refills is important. So those are some strategies to think about with self-management. So I think then the other probably tough area and a new focus in healthcare, which I think we've been doing in geriatrics for a long time, but we're actually naming it something now, and that's called de-prescribing. So really thinking about if someone's on a lot of medications and you identify they might be on too many, maybe there's some that aren't appropriate or they're not sure why they ever started this, de-prescribing consideration is important. So de-prescribing is the process of identifying and stopping drugs which either create harms or where the risk of the drug now outweighs the benefit. Or in the case of some drugs where there's just no clear indication. And I will say, being on the West Coast here, I always found we kind of had a West Coast phenomenon where for older adults who had traveled through the country to live with different children, sometimes by the time they made it out to our clinic, they were really on a lot of medications because nobody wanted to stop anybody else's prescription, but new things were started. So no one's really stepping back and looking, because the patient may say, oh, I'm still going to plan on going back. My mom, for example, still goes to her cardiologist an hour away because she developed rapport and relationship with that person. And so I'm sure the current new docs in the Seattle area may not be comfortable changing those medications. So really thinking about de-prescribing when the intent of therapy is not clear is important, or certainly if there's causing risk. So in the prescribing of a medication, I think it's important to think about the process. So there'll be an indication and a medication is started. Immediately, we should always be weighing the benefit versus risk. And for use of medication at any point in our lives, the benefit should outweigh the risk. That's communicated to the patient or their caregiver and then monitored, and that's kind of the prescribing cycle. In de-prescribing, we just take that cycle and kind of go in reverse. We kind of basically have to diagnose, if you will, or assess that there's an indication or a potential indication to stop a medication. And that should be based on the fact that there's recognition that there's a low benefit of the medication versus what seems to be a higher risk or maybe an emerging risk. Maybe as the patient has aged and their kidneys are now older, not working as well, they're starting to become a little toxic on the drug and they either need a dose reduction or need to get off of that medication. So we need to deprescribe. I think in deprescribing, two critical steps are communicate and monitor. Because if you are used to doing something like taking a medication for years and then someone undoes that for you, that can be kind of distressing because that routine of taking certain medications, for especially people who are really adherent, becomes really a priority. And if you remove something from that routine, you have to make sure the patient is very clear they no longer need to take that. I've seen a number of examples where the communications don't happen, the automatic refill keeps coming, the patient stays on the drug, they continue to have the harm, and no one's recognizing the harm because the medical record says we stopped that drug 3 months ago, not realizing the patient's continuing on the therapy. So the communication and monitoring when deprescribing occurs is really important to make sure everyone involved in the care of the patient and the patient or their caregiver, if someone's supporting them with meds, are clear. I also want to clarify, deprescribing, it should be just a regular part of good prescribing continuum. It's not about denying effective treatment. It needs to be positive and patient-centered and making sure the patient feels that's the right step. So it has to have that shared decision-making. So I have a case here to help us kind of look at some potential deprescribing opportunities. So a 75-year-old woman is in clinic today complaining of nausea. She first noticed the symptoms 3 or 4 days ago. She's accompanied by her daughter who reports that her mom has been somewhat confused over the past few days. So we have 3 to 4 days of nausea and confusion. Past medical history is atrial fibrillation, memory problems, hypertension, urinary incontinence, insomnia, and history of falls. Okay, so let's remember nausea and confusion are kind of the new onset symptoms. So here's her medication list. So if you think back to that chart I had of the medications and the conditions, that's the first thing I would do. And then I would think about the symptoms she's having as sort of, first think about them as, could these symptoms be side effects of any of these medications? Because that is my opportunity for deprescribing. So looking down her list, she's got the warfarin, which is kind of the anticoagulant. She has digoxin, which is controlling her heart rate for the AFib. She's on aspirin, which is probably preventing a heart attack or stroke. The low tensin is for blood pressure. Oxybutynin is for urinary incontinence. Temazepam is a drug for sleep. Advil PM is also being used for sleep, and Advil PM is ibuprofen and diphenhydramine, which is Benadryl. And then she has omeprazole for her stomach. And then just to note, her creatinine clearance here is 45, which is a little above the cutoff of 60 mils per minute that we kind of use for when some drug therapies need adjustment in their dose. So just take a look at that, and I realize we have very much a virtual course. So let me point out a few things to think about. So I would actually check in on the continued need for both the aspirin and the warfarin. That would be something that might flag for me, because with the upset stomach and being on aspirin, even low-dose aspirin can cause GI problems. And so that would kind of red flag for me of, is her nausea potentially gastritis, or worse yet, could it be an ulcer forming? And could we help correct that by taking away the aspirin? And if we took away the aspirin, is that safe for her given her AFib and other conditions? The oxybutynin is the anticholinergic being used for urinary incontinence, potentially could cause some confusion. Kind of dueling up with that, what concerns me is the Advil PM. She's got Benadryl or diphenhydramine that she's getting at bed along with the oxybutynin, so she's got kind of 2 drugs that potentially have the anticholinergic effect. So I'd probably talk to someone. If she's confused, I'd probably be talking to the daughter about who recommended the Advil PM. Often if it's an over-the-counter product, it wasn't recommended by the health professional. It was something that either the patient picked up or a family member picked up to help out. The temazepam is a sleeper agent. It is while it's a safer benzodiazepine to use in an older adult because it doesn't hang around as long, it still causes drowsiness, dizziness, and it hangs around. And so that could also be contributing to confusion. So I would, and then the omeprazole might be there to treat the stomach upset, so that might be able to be resolved if we could figure out what's causing her stomach upset. So you can see in the deprescribing world or view, there's actually several opportunities here. You might not want to make all the changes at once, but if you sleuthed it out and you found out she actually doesn't need warfarin and aspirin because they're both, one's an antiplatelet, one's an anticoagulant, she only needs the anticoagulant, you might then have your first step be reduce the aspirin. But the temazepam, the oxybutynin, and the Advil PM, I would probably at least try and resolve the Advil PM because that's creating confusion. I would think through, why does she need something at sleep every night, and do we have other ways we can help her with sleep? And kind of take it one step at a time, but there are potentially some opportunities there. Oh, the other thing I noticed on here, the digoxin 0.125 was reduced from 0.25 1 month ago. I would make sure that happened. Again, it may have been best intentions and noted at the provider's office. The patient may have gone home and realized, oh, I still have 90 left of the 0.25. And if you just filled a prescription, any of us would know it just doesn't make any sense to stop it and go refill a different one at a different dose. And so sometimes for patients, they'll think, well, I'll just finish out the rest of this one before I start the next one. And digoxin, if the dose is too high, could cause some stomach upset as well. So that's kind of an example of how I might approach that. The last couple principles here are really to keep us thinking about that drugs are not all bad. I don't want to totally make you think drugs are too scary in aging. We need to be careful, we need to be thoughtful and intentional in how we use them. But I think that the old, the quote, to treat or not to treat, instead of to be or not to be, I said to treat or not to treat. I think it's important to treat with intent if you're treating. And so what I do see in aging sometimes is untreatment and undertreatment. Because untreatment sometimes is, well, this person's older, I'm not sure they're going to benefit, when actually the data might show they have a lot of years left they could benefit from the therapy. And the studies show that 50% of older adults were not prescribed an indicated medication. So I think it's important, if someone has the ability to gain the benefit of that drug and it is the best choice to treat the condition, they need to be on it. Obviously that needs to be weighed against other medications and side effects and things like that. But if the benefit outweighs the risk, they need to be treated. Undertreatment is probably the more common problem that we risk. And that is because in geriatrics, and those of us who are trained in geriatrics or gerontology, we're probably taught start low and go slow with drug dosing, or probably with any treatment. That's a great statement. Start the dose low, and doses you start in geriatrics are often half what they are in a younger adult. Go slow means take it gently. Don't just ramp them right up to a full therapeutic dose. And keep in mind, a lot of the therapeutic doses you see published were from studies in younger adults. So an older adult, based on their kidney function, may not quite need that same target dose. But my words I add to it is, but do go. So start low, go slow, but do go. I work in diabetes, and I gave you an example here that is something that is not uncommon to see, where someone is very thoughtful about starting someone on a low dose of metformin to minimize stomach upset, because older adults are at greater risk for that. So the initial starting dose of metformin is 500 milligrams a day with food, but sometimes in geriatrics we'll start it at 250 milligrams a day. And then, but you're supposed to, on a weekly basis, be increasing the dose to get up to, in a non-geriatric adult, you want to get to at least 1,500 milligrams. You may not need to go that far in an older adult, but you need to treat to effect. So ideally, the A1C is coming down 1 to 2%, which would represent about a 30 to 60 milligram point change on their averages on their meter if they're checking their glucoses. But what I see sometimes is a year later, a person will come in with uncontrolled diabetes to clinic, and they're still on 250 milligrams a day of their metformin because they either never heard or never were given the instructions, or didn't process the instructions they were given that they needed to titrate the dose. Or maybe someone thought, let's start them on 250 and I'll see them back in 3 months and we'll see how they're doing on it. And they were trying to be very thoughtful and start low and go slow, but they didn't go. So it can result in some clinical inertia. So it's really important to make sure that if we start low and go slow, we continue to push drug therapy until we get to those treatment targets that we're looking for. So we've talked about, you know, if you treat with intent, but also making sure, we've talked about a lot, don't do any harm. And really identifying harm that drugs could be causing, I think, is a key intervention that those of us who work with older adults can make. I've helped you understand some real reasons why people don't pick up on the fact that a drug could be causing a symptom, why they interpret sometimes it's just part of aging, why they might not connect that it's a drug because they'll think, I've been on this drug for 20 years. It's never caused a problem before. Why would it be this drug? And so really thinking about the changes that happen in aging and how this can actually be a setup for someone becoming overdosed on a drug that they've taken for many years even is important. So potential clues to overdosing including your patient just seems drugged or dopey, dizzy, or confused. Those aren't usual effects of drugs. They could be side effects of drugs, but often can be helped with dosing. But if you see someone just seeming really drugged or dopey, it would be very good to intervene because you can imagine that they're right in front of you. Then they have a risk for falls, they have a risk for confusion, they could make some poor decisions, they could not be able to care for themselves. If you know drugs and you know doses and you look at something and think this dose seems really high, it's good to intervene. It may be that, so go back to that Zolpidem or Ambien case I showed you towards the first part of the presentation. That's an example where a 10 milligram dose might be something that a 30-year-old would take. And so maybe the older adult had someone give them a medication saying, here's what I take, not realizing that's a big dose for an older adult. And then the thing that really trips people up, including healthcare professionals, is that doses have been the same for years, so people will think, well, that drug can't be causing the problem because they've been on it for years, when actually the body has been aging and changing over the years and maybe not be able to handle the drug the way it did when they were younger. So some physiologic considerations to help you make sense out of this is our bodies have absorption of drugs, distribution of drugs, metabolism, or we chew drugs up to get rid of them, and then excretion of drugs or elimination. So distribution of drugs is affected with aging because older bodies, no matter how much you try and maybe wish this doesn't happen, older bodies, just because of the aging process in general, have a greater percent fat or lipid compartment than lean tissue. What does that mean? Well, what it means is drugs that soak into fat last a lot longer because there's a bigger lipid or fat compartment in the body. And it means that drugs that soak into body water can build up to toxic levels more quickly because there's less body water. Body water tends to be in the tissues and the muscles. And if you have less of that, less lean compartment, those drug levels can be higher. So I've given you some examples there. Valium is an example of a drug that is very fat soluble and hangs on, where the half-life of Valium, meaning it would take a few, the half-life is how long it takes for the drug level to dip in half. And you need about 3 to 5 half-lives before you really have appreciably gotten rid of a drug. So in someone who's 20 years old, the half-life of Valium might be 10 hours. In an older adult, it might be 100 hours. So it really hangs on for a few reasons we'll talk about, but Valium is kind of a big culprit. So in aging-related care, we try and stay away from the Valium-related drugs just because of that. An example of a drug that stays in body water is ethanol, which is drinking alcohol. So if you've ever heard an older adult say, I just can't tolerate alcohol anymore. I have one drink and I already feel it. There's a reason they're feeling it. It's because the concentration is much greater than when they were younger and they had a lot more lean compartment with a lot more body water. So those are the types of things that we need to be thinking about for those of us in prescribing roles with medications or with that medication focus. The kidneys, and this was the first question on your quiz up front, The kidneys have the biggest effect on drugs as aging occurs, and that is there's a gradual decline in the ability of the kidneys to eliminate drugs and their metabolites, if those metabolites go out through the kidneys as we age. So in very, very general, but I think this is a good kind of bedside way to do the math. If you don't have a creatinine clearance or whatever in front of you, or GFR, kidneys decline about 1% per year after the age of 50, kidney function. So if you figure by the time I'm 80, I'm going to be about 30% down on my ability to have usual glomerular filtration that eliminates drugs, which could imply that I need like 30% less of a dose of a drug that's 100% cleared through the kidneys. So pretty important. The example I used earlier from a patient case of mine, ranitidine or Zantac, that is cleared through the kidneys. So that's why that drug can cause those symptoms at high doses, but it can also even cause the symptoms of headaches and confusion at what might seem more regular doses in an older adult if they have a big decline in kidney function. And Zantac is available OTC. It's something that people might think, I've taken Zantac for years, you know, and all of a sudden they're getting headaches and they're coming in for headache treatment when it may be just the Zantac levels are getting too high and it's actually challenging the brain. And then the liver actually hangs in there quite well with aging. The main thing we do to try and just be on the safe side is we know that as aging advances, there is some reduction in liver metabolism. And what the liver does is it processes drugs, many drugs, not all drugs, but it processes drugs and it tries to inactivate them or build them into drug metabolites that are easier for the body to pee out and get rid of the extra that way. So in the process of inactivating drugs, the liver, as it gets older, gets less good at really creating metabolites and that sort of thing. So you can have more of a parent drug hanging around than when someone was younger and they were better able to chew it up. The liver's pretty good at doing these gluing reactions where it glues a drug to something that is highly polar, meaning your body can pee it out easily. So those types of reactions aren't really affected much by aging. So an example would be, I talked about Ativan or lorazepam being used in older adults. If you're going to use a benzodiazepine, a lot of times Ativan is one of the ones used because your liver can just glue that together. Ativan is highly related to Valium. You wouldn't use Valium because Valium is something that requires processing by your body. Alrighty, so I think when it all comes down to it, the real key in aging is thinking about appropriateness of medications. The Beers criteria, which many of you are probably familiar with, is, so Mark Beers was a physician who did a lot of research to look at, are there particular drugs that are just extremely high risk in older adults based on these pharmacokinetic and pharmacodynamic and sensitivity changes I've talked about, and drug disease interaction risk. And so a list was created of drugs to avoid, and that's what's referred to as the Beers list. If you hear of a drug being on the Beers list, that's what that means. The Beers criteria were updated in 2019, and I have the citation there. What's really nice is it now includes strength of evidence and a recommendation, but it also has a couple of tables, and one of the tables is this drug disease interaction I was talking about. So if a drug potentially could worsen an illness that the person has, that's also included. So some of the key drugs that bubble up to the top on the Beers criteria are any anticholinergic, which is that like Benadryl or diphenhydramine, and that includes antidepressant drugs that have high anticholinergic action. And that would be drugs like amitriptyline or paroxetine. Paroxetine goes by the brand name of Paxil, and I actually remember the brand name of amitriptyline, but I don't know if anyone uses that anymore. But amitriptyline in very low doses is still sometimes used in neuropathic pain, but if avoidable or an alternate agent can be used, that would be preferable. Nitrofurantoin makes it on the list, which is macrodantin for urinary tract infections, and that sometimes confuses people why it's on the list because it's sometimes used in geriatrics to treat UTIs. The caveat is if the creatinine clearance is less than 30, or it's going to be long-term. Sorry about the speller there. Looks like my finger slugged on the M. But if it's going to be long-term use, like preventative therapy, or the creatinine clearance is less than 30, the risk of the toxicity with the drug is too great, so it shouldn't be used. The cardiovascular agents listed here, like the alpha-1 blockers, antiarrhythmics, immediate release nifedipine. So long release nifedipine didn't make it on the list. And then digoxin doses greater than the 0.125 in older adults are considered, should be avoided. Barbiturates are not seen much anymore. That's the phenobarbital and pentobarbital drugs that used to be highly used, but they're really not used much anymore. And then of the diabetes drugs, wanted to point out the sulfonylurea, long-acting sulfonylureas, including glyburide, which is still very common. It's available on the $4, $5, and $6 prescriptions at pharmacies, so it's very low cost. We should avoid its use in older adults. It's long-acting, but it also has an active metabolite, and so the risk of hypoglycemia or low blood sugar is much greater than the alternate would be to use like glipizide or glimepiride. And glipizide is, I think it's glucotrol is the brand name, and glimepiride is Amaryl. But so there's two alternate sulfonylureas to use in older adults if a sulfonylurea is used. So key medications that the aging body is more sensitive to include the drugs that can cause orthostatic hypotension, medications with central nervous system effects, and then the anticoagulant warfarin. Those are really key ones. And then start the dose low, increase slowly, but do go. So increase it all the way if you need to. And then just to close, I wanted to really help us think through the importance of transitions of care. And I think this is actually principle number 9. But you want to pass the baton carefully and thoughtfully, and do so at every transition of care. So depending on what your role is, you may be someone who, if you're a caregiver, you may be there at going into the hospital and coming out of the hospital, or going into the nursing home or coming out of the nursing home, or SNF, whatever it is for the patient. And for those who work in certain settings of care, it's important to grab that baton and make sure it's passed clearly and thoughtfully, so the patient ends up on what medications were in the plan of care, and that there's clarity on what from their home medications they're supposed to keep using. These transitions of care can create major challenges for older adults. So any transition, home to hospital or emergency room, hospital to rehab, long-term care or assisted living, rehab, or long-term care or assisted living to home. So all the way around. So some examples you might see is duplication of medications, because the patient might have the medication but under a different name at home than what's given in the hospital. So sometimes they can end up taking twice the dose because they're thinking they're taking 2 different medications. So an example is the same drug duplication of a hospital discharge instruction to use metoprolol, but the patient already has toprol at home, which is metoprolol. The second same drug issue would be Vasotex, so brand names and generic names. A lot of times in hospital settings, we're using generic names, and patients may have gotten a brand name in the outpatient setting. And so that can create a lot of confusion because patients don't know the names. It's really hard for us to pronounce the names. Can you imagine for them? It's often a lot easier to say the brand name than the generic name. So same drug in those first 2 cases. Same drug but different doses in the third case. You have levothyroxine at 100 microgram daily, and then Synthroid at 88 microgram daily was at home. They're both levothyroxine. Would the patient know that? Not necessarily. So that patient might end up taking 188 micrograms of a thyroid pill daily, which it can have its risks. And then sertraline, which is an antidepressant, goes by the brand name of Zoloft. Taken at bedtime, and it does cause some drowsiness. Ambien is a sleeper taken at bedtime to induce sleep, but the patient might go home and think, I already have a drug for sleep, so I don't need to take this one the hospital gave me, thinking that the sertraline is actually for sleep when it's actually being used for depression. So their depression, in this case, would go untreated. So, and actually the Ambien would make it worse because that's a drug-induced cause. It's a depressant. So, so you can see transitions of care are so critical. And when a patient, if we can help patients clarify through the understanding what all they're taking and then having that on one list, it's really, really important. And it's so helpful to all of us as healthcare professionals when we interact with the patient. So kind of an acronym I keep in the back of my mind when I think about what can we all do to really support medication health and safety for older adults is we can care. And so the acronym is confirm the goals with the patient. Again, I talked about understand if they gain their understanding of their medications and what goals they're trying to achieve. Assess their needs. Depending on your professional background, how you intervene once you assess their needs may be different. But if the patient reports concerns to you, anybody with any professional background or a neighbor should be able to say, if you have a concern, you need to call your prescriber and let them know. So that's important. Duplications in therapy, if you pick up on them, are really important to pick up on. If a patient reports they're having challenges with adherence, that's something to listen to. Those don't magically resolve. And if they need education, if they really just don't seem like they understand why they're taking the medicines or how they're taking them or what they're supposed to do with the medicines, they need education. And then reporting those concerns. And I would also encourage to think about where you need to report the concerns, and triaging obviously is based on level of severity. So if there's a really acute, severe situation, you might call 911 or send them to the emergency room if that was appropriate. If it's not an acute, severe situation, but you feel it's an immediate need, there's a couple things you can do. If you're not clear this is a medication-related problem and you just need a consult, call their pharmacist. Just say, here's what I'm seeing. Could this be the medication? To help you gain clarity on, do I need to call their physician or nurse practitioner or PA, whoever's prescribing it. So I think kind of looping in the pharmacist early in medication-related concerns to help make sense out of it is important. If it's not an immediate concern and the patient just has a lot of questions, then do send them back to their pharmacist, because that is part of what the pharmacist is there to do, is help the patient understand the purpose and goals of the medication. Or they can certainly go back to their provider, but sometimes patients don't have a provider visit set up soon. And so you don't want them to delay for 6 months of wondering about a problem before they have it addressed. And then provide encouragement. It is really hard to take medications. Even if you just take one medication once a day, there's always a time that you might have a goof up on that adherence. And so I think it's really good to encourage people when they're doing a good job with their medications, and also encourage them if they have concerns that their provider would want to know about those concerns. I think sometimes our patients and clients can sometimes think, well, you told me to do this, so I better not question it. When actually, I think we'd all want to be questioned if the patient had a concern. So encouraging the patient both for doing well with the medications, but also for sharing concerns or challenges they're having is important. And then I've also included in your handout some resources. The Medline Plus is quite helpful just for even patient information. The AARP has a lot of different information. It has a drug interaction screener. I think we need to be careful that patients don't get in there and try and be their own pharmacist and be screening for drug interactions. But in that case, I usually encourage patients, if you're screening for drug interactions, that means you might have a concern. So just make sure if you have multiple pharmacies, make sure one pharmacist has everything so they can be looking at that. Because that's a regular professional service that pharmacists are doing, is screening for drug interactions. But they do have a pill identifier. So if you're out with a client and you realize, I have no idea what these pills are, they're not in a bottle, you can go on the AARP website and put in the number you see in the score mark or whatever it is, and it'll show you pictures and you can actually see, oh, that's what that pill is. They have drug information, and they have a symptom checker so that you could see, could this be a drug-induced problem, which I think is quite helpful. And then just in parting, I think my final advice is this cartoon I've always liked when we talk about older adults and medications, and that is never take a pill that has more side effects than you have symptoms. And so again, encouraging people that a pill isn't the answer for everything. But if you have a condition that needs a pill and you have a professional who's evaluated you need the pill, then we need to do the opposite, encourage people that in this case, the pill is really important to use. So, but helping people understand that every ache or pain or symptom that you have doesn't necessarily need a pill. So thinking through what could be causing it and thinking through, especially removing a drug if a drug's the problem causing it, or helping patients understand the value and high impact of lifestyle modifications if something they're doing is actually causing the problem before they go to the pill is always important. So what I've also done in your handout is included just a couple practice cases. I won't go through them now. I think, Barb, do we want to take any questions that come in? But there's 3 practice cases, and then I put kind of some concerns to think about with each case. So feel free to work through those or chat if you're in groups, and let me know if you have any questions. Thanks.
So I actually have some questions that
Okay.
have been coming in. This person says, I own a care management consulting practice to family caregivers in many states. Are there consulting pharmacists in practice available for working with patients and their healthcare providers across the nation? There are many healthcare providers, especially in rural areas, that aren't associated directly with the healthcare system that offers clinical pharmacists. So you don't need to repeat the question because they can hear me.
Okay, thanks. No, it's a great question, and what's available state by state can vary. So there are consultant pharmacists, and the American Society of Consulting Pharmacists or Consultant Pharmacists, ASCP, I think it's ascp.org. Anyways, there you can even find consulting pharmacists there. So that would be a resource I would recommend to look at their website and put in the state you're in, and there are some that names that will pop up. The other thing is a lot of the pharmacies that distribute to assisted living facilities and long-term care and skilled nursing facilities have consultant pharmacists on their team. And so they may have a setup where they can make that consultant pharmacist available. And then more and more, there are some community pharmacies actually available to do medication reviews. And in many of those cases through Medicare Part D, that they can actually have that as part of a regular service available through Medicare. So those are a couple strategies that come up. And then in rural areas where sometimes a pharmacy and a pharmacist is the only health professional in the rural area, I would encourage to potentially connect with the pharmacist in that town to see if that pharmacist is able to support the patient. Pharmacists are in every school of pharmacy curricula since for the last many years, including from when I was trained, but have had geriatrics training in their curricula. So that's part of the normal standard core curricula for pharmacists. And so they should at least have some good basics understanding of what to look for and how to assess situations in older adults. Yeah, thanks.
Okay, and Terry in Missoula has just reminded me that I'm actually off because I'm actually working 1 week ahead with our handouts and our PowerPoints. We have 2 more sessions, so please don't give up on us. We will have a session on Tuesday next week and then Tuesday the week after. So this was our 8th session. Sorry about that. So another question is, I'm an RN. What apps can you recommend for accurate and comprehensive medication information for my own learning?
Oh, that is a good one. I'd almost have to look at my phone and do a little research, but there are a couple good ones, and I'm blanking on the name. Can I get that back to you, and you can make that available next week? Yeah, there are a couple. There are, as far as apps on the phone, there are definitely, so there's like Micromedics and Hippocrates and some of those that you can get as apps that are also available on your computers at health systems and things like that. But there's actually a good app. I want to remember the name of it because it has good information and it's helpful around costs also, which a lot of times comes up as a question from patients.
Which leads into our next question, and that is that finances is a big consideration in older adults. GoodRx.com touts cost savings at different pharmacies. Any paying cash bypasses insurance review for compliance. With cost constraints, it's difficult to advise using one pharmacy for drug interactions review and then having a relationship with a pharmacist for counseling. Do you advocate using one pharmacy?
I don't, I think realistically, we were going to keep this real. Patients can't necessarily use one pharmacy. So I encourage them to make sure your pharmacists are aware of everything you're on. And for a lot of patients, that means that's the in-person pharmacist in the community setting that they get those initial prescriptions from. And then they might use a pharmacy benefits manager or mail order for their regular prescriptions. I also always remind patients that mail order company has a pharmacist available to talk to. So if you prefer phone or online, you can do that through that company. But I think sometimes it's not realistic that patients only have one pharmacy, but the fewer pharmacies they can use just to keep the information in a central or two central locations is more ideal. So I think that that's probably the more realistic approach. And there are a lot, I also encourage patients to vote with their feet. If you're at a pharmacy where you don't feel there's time for you, there are a lot of pharmacies that would love to spend time with you. So finding those high-touch pharmacies that'll take the time for the counseling and the education, at least as kind of your home in-person pharmacy, is, I think, really important. As far as cost, I am a big advocate that, because I've been in healthcare a lot of years, and I follow the literature, and there's some old drugs that work really well, and they're much less expensive than some of the newer drugs. So I think it's important that if a new prescription is being prescribed and it's expensive, that the question is asked, is this the only alternative, or is there a less expensive alternate that I could be using? A lot of pharmacies now, because of costs of healthcare, have what we call the $4 prescriptions. I think some of them are up to $6 or $7 prescriptions. But because the cost of the drug is so small, they've just started taking it, and instead of doing it as insurance, they'll do it as a $4 prescription per month. And a lot of common drugs are on this list. So if you go on to a lot of the big pharmacies' websites, you can find out what's on their $4 prescription list. And that can even help guide your provider who's helping with selection of therapy. Unfortunately, in healthcare, we aren't all connected. So a lot of times the person prescribing has no idea what the cost actually is, or if your insurance company will cover it, because there's so many different plans. So if you can have, and the app I'm going to send to you is one that actually has the insurance plans on it, and it's updated, is supposedly live, but at least it can help you with a sense of, will this plan cover this, and at what cost will it cover it at?
If I can raise a question that actually brings up an important point that you're alluding to, and that is a person's Plan D pharmacy formulary, when they're started on a new prescription, may not carry the drug that they're started on. To what extent do pharmacists take a look at that in the community, that they're perhaps on a Plan D formulary that doesn't take this medication but might take this other one?
Well, they look at a lot, and so the pharmacists, but unfortunately the way pharmacy computer systems are set up, and the fact that those formularies are changing and there's hundreds of them, sometimes what the pharmacist has to do is actually almost like a fake prescription to query the current 3:04 p.m. in the afternoon on May 21st type of interaction with the insurance company to see if it's covered. And if not, what the pharmacist will often do is call the prescriber and suggest changing to what would be covered. Or they'll let the patient know that, this isn't covered. If you want to wait a bit, I can try and get it changed to the other prescription if they think they can't get a hold of who's prescribing it right away. So that's a really important thing. I would say for patients, for all of us as patients, if you go up to a pharmacy counter and they ring you up and it's $700, before you grab that bag and walk away, stop and ask questions. There could be, sometimes there's incentive programs so that if you fill out the right paperwork, you can get a discount for the medication. There's contracts with different insurance companies, and those are changing often. The first of the year is a big chaos sometimes in pharmacies because the contracts have often changed, or if people changed plan benefit at the first of the year, formularies change, and all of a sudden what was covered in December isn't covered in January. So there's a lot of important work that needs to happen, and unfortunately with some of the older adults I work with, I've had them say, my prescriptions are normally you know, $34, but it was, you know, $300 this month. And I'm like, oh, I wish you would have. And I think what happens is the person ringing you out often is not the pharmacist. So if you know, if we can help our clients understand, if you're concerned about the price, ask for the pharmacist and ask if they have any ideas. That's a great starting point. Yeah.
I don't see any other questions. Did you have any questions? So thank you.
Okay, thank you. And I'll get the name of the app to you. Thanks.